Welcome, everyone. It is noon, so we'll go ahead and get started, and it's fine if people are joining us along the way. I wanted to introduce Molly Brown. She is our new Heartland Telehealth Resource Center Program Director, and we're thrilled to have her here on the team, and I will pass it to her to get the session started for us.
Thank you, Christy. Welcome, everyone. As she said, I am the new Program Director for the Heartland Telehealth Resource Center, and we're glad you're joining us for the HTRC Education Series focused on telehealth, billing, coding, and policy. There's just a few notes before we begin. This session is being recorded and we'll share it with you afterwards. Your microphones have been muted, and you can unmute those if you have questions during this session, or you can use the chat box to talk. Your completion certificates will be emailed, and it's important to sign on with your first and last name on the webinar so we can identify you and note your attendance. You can change your name if you haven't used your full name by clicking those three dots that are on the Zoom screen in the top right corner. So let's get started. I'd like to introduce Rochelle Martin. Rochelle is a local attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing and reimbursement, HIPAA privacy and security, health information management, and regulatory compliance. We're excited to have her here today to talk about telehealth and therapy disciplines, including the outlook in these areas. So now I'll turn it over to Rochelle.
All right, thank you, Molly. Thank you, Christy. So the topic for today, as we've gone through these webinar sessions over the last year, we've tried to touch on different provider types, different facility types, and the rules surrounding telehealth for each. And one that we haven't taken a deep dive into yet are the therapy disciplines. And I thought it would be a great idea to do that because hopefully, knock on wood, hopefully the end of the federal public health emergency is in sight. I guess hopefully or unhopefully it's positive in many ways, and then in other ways we've got the unwinding of a lot of the rules and flexibilities that came about during the public health emergency. And the therapy disciplines, physical, occupational, and speech therapy, were very significantly impacted by a lot of these flexibilities, arguably maybe even more so than providers who often bill telehealth even outside of the public health emergency. So I'm going to start this afternoon by talking just a little bit of a reminder, if you can remember what life was like pre-COVID, what the rules were for telehealth with respect to the therapy disciplines and why, and how we got to some of the flexibilities during the public health emergency. And then what things may look like moving forward in terms of these therapy disciplines being able to provide telehealth and which services and for how long, at least with what we know today, and some possible legislation that may be on the horizon affecting these disciplines. So back prior to the public health emergency being declared, kind of two bodies of rules or laws really dictated how telehealth worked under the Medicare program. And under the Medicare program, we have the Social Security Act defining telehealth as a covered benefit. And that's where we see the definitions of originating site. That's where we see the rural health geographic element for telehealth services. And that's why I'll sometimes say it will take a literal act of Congress to make some of those changes, because it is in the Social Security Act, and we do need federal legislation to make some of those changes permanent. Then we have federal regulations that help define or interpret some of the provisions of the Social Security Act. For example, the Social Security Act uses the term interactive communications, but doesn't define that. It's in the regulations and Health and Human Services that interpreted interactive communications to mean generally audio visual. And that's why relaxing those requirements to allow audio only during the public health emergency is something that could be done by the agency through rulemaking, rather than requiring an act of Congress to make those changes. So one of the things that is defined in the act the Social Security Act are what types of professionals can provide telehealth services. So we've come to know these as the distant site professionals or eligible distant site professionals. And the language in the Social Security Act says that the secretary or the Medicare program shall pay for telehealth services furnished via, there's that telecommunications system that's defined by the agency, by a physician or a practitioner. So that's really the language that creates this sort of restriction on who can provide telehealth services, typically outside of the federal public health emergency. So physicians is also a defined term under the Social Security Act. That includes MDs, DOs, dentists, chiropractors, optometrists, and podiatrists. And then that term practitioner, that they can be provided and covered by a physician or a practitioner, that's also a covered or a defined term under the Social Security Act. So even outside of the federal public health emergency, physician assistants, nurse practitioners, nurse specialists, nurse anesthetists, nurse midwives, social workers, psychologists, and dietitians or nutrition professionals can deliver telehealth services. Now, that is also further restricted by the list of covered telehealth services each year. So it doesn't mean that a physician assistant, a physician, a nurse practitioner can provide any service whatsoever via telehealth. Not only do they have to be an eligible distant site practitioner, there has to be an eligible originating site, an eligible geographic area, and an eligible telehealth service. So that's where we're restricted through the Social Security Act outside of the public health emergency. So notably, we've got a couple of practitioners or that we would normally think of as practitioners that are missing from that list, right? We've got physical, occupational, and speech therapists that are not in the Social Security Act definition of a practitioner who can render telehealth services and be paid for telehealth services. So that was really the restriction prior to the public health emergency. Then March of 2020, right, we get this flood of flexibilities and waivers on telehealth services, allowing us to provide telehealth services to patients in their home and all of these other things that are great. But the definition of a distant site professional was still there. So for weeks, physical, occupational, speech therapy were kind of stuck. And I remember our good friends and neighbors on our street in our neighborhood, one is a physical therapist, and there was a lockdown and his clinic was closed, but physical therapists couldn't provide telehealth yet. So they were kind of in a bind and making sure their patients were taken care of, yet not being able to deliver that in a telehealth modality to be able to bill under the Medicare program. So it wasn't until April 30th, which in retrospect from March to April doesn't seem like that long, but I remember at the time it felt like forever before this announcement finally came out by CMS that said for the duration of the COVID-19 public health emergency at a federal level, the one that is still in effect today, that Medicare is waiving the limitations on the types of clinical practitioners who can furnish Medicare telehealth services. So prior to that, it was physicians, it was certain practitioners that didn't include the 3 primary therapy disciplines. Now, April 30th, 2020, excuse me, through the end of the public health emergency would be eligible distant site practitioners to render telehealth under the Medicare program. What that did then, between March and May, we had also kind of a flurry of additional codes being added to the telehealth list at that time. So this was all kind of happening at once. And what I've pulled today, the table that you see on this slide comes directly from the list of eligible telehealth services that's in effect right now under the Medicare physician fee schedule. And so there's sort of 2 paths that these newly covered telehealth codes were identified on the telehealth list. And this is true regardless of whether it's therapy or not, but it becomes particularly important, I think, in these therapy disciplines. So if you look at this, if you look at the list of covered therapy services that are typically not covered outside of the public health emergency, you see two different statuses. So one of the statuses, it says temporary addition for the public health emergency. And there are a couple different dates. Some were not added until 2021. Some of these were added the same day that Medicare announced therapy professionals can be distant site professionals and bill Medicare. They also added these therapy codes to the telehealth list the same day. You then also see those above and below that say available through December 31st, 2023. So that's kind of two different buckets. And the ones above and below, the ones that say available through December 31st, 2023, those are what we're calling Category 3 telehealth codes. They're in this bucket of telehealth services that are temporarily added, not only through the duration of the public health emergency, but through December 31st, 2023, even if the public health emergency ends sooner. And in the meantime, providers can submit requests to have services added to the telehealth list and provide evidence and documentation of how or why these services, these therapy services, are either similar to other codes that are already on the permanent list of telehealth services, or they have clinical efficacy and they're safe and should be added as telehealth services. Those are what we call Category 1 and Category 2 telehealth services that can be added on a permanent basis. But the ones there in the middle, the temporary additions, when the public health emergency ends, the day that the public health emergency ends at a federal level, those CPT codes will no longer be on the list of telehealth services, regardless of who the professional is, physician, nurse practitioner, PA, or physical therapy. They will be gone that day. Well, as I'm saying that, it occurs to me that we're in February and the deadline to submit requests to add services to the list of permanent telehealth services is in February. And I apologize, I don't know the exact day off the top of my head. But if you are a therapy professional or work with therapy professionals and have an interest in these services being added on a permanent basis, now's the time to submit your request to Medicare to make these services eligible on a permanent basis. Last year, what we saw in the physician fee schedule, the one that's effective right now, Medicare said we got some requests, but we didn't get any by the deadline to consider with respect to various services. So that's going to be very important this year. And if you miss the deadline this year, certainly next year by February, getting those requests in. So then we have occupational therapy services. Now the list is a little bit shorter, but they also use a lot of these same therapy modality codes. But the ones that are specific to occupational therapy that are the initial evaluations, depending on the complexity, and the re-evaluation are on, again, this is the current Medicare list of approved telehealth services. You can see that these fall into that category, the Category 3, that will continue to be available as telehealth services through December 31st, 2023, which also means there's an opportunity this year and next year to submit requests to have these added as telehealth services on a permanent basis. And hopefully then January 1st, 2024, if Medicare has enough data to show that they are like or similar to other covered telehealth services, or they're effective and they're safe and can be delivered effectively in a telehealth modality, that they could be added as permanent telehealth services in that way. And we've got a fairly long list of the services that are added as speech therapy services. So you continue to see kind of the two buckets, the ones that are temporary additions, meaning the ones here at the bottom, I'm pointing on my wrong screen here, so you can't see my pointer. The ones here at the bottom, these will go away when the public health emergency ends, as well as this little guy up here, 92508. But the others available through December 31st, 2023 will continue to be available through that date, even if the public health emergency ends sooner, and we still have opportunities to request this year and next year that Medicare add those services as telehealth services on a permanent basis.
So one thing that we've got a question in the chat that I wanted to get to before we moved on.
So let's go ahead.
Yeah, sure. From Joey, it says, can these CPT codes be used for home health services?
So that's a great question. I'm going to, there's actually a specific CMS FAQ that I'm going to get to in just a little bit. And it talks about therapy, if it's part of the bundled payment for home health, for skilled nursing facilities, or any other bundled payment model, then no, the flexibilities during the public health emergency don't change that bundled payment structure. However, if the patient who is getting home health services, if the therapy falls outside of that bundled payment, and I apologize, I can't think of an example off the top of my head for home health, but like in skilled nursing facilities, that the patient's not in a Part A stay where the therapy is included in the consolidated bill for the Part A stay, both for room and board and nursing services as well as therapy, but instead is maybe in a Part B stay, then these therapy services can be billed separately. So it really hinges on whether the patient is in a bundled stay that includes therapy as part of that bundled payment or not. And if the answer is no, then the therapy codes can be billed separately as professional services paid under Part B. Great question. And I'll show you the specific, the CMS FAQ in just a few minutes on that. As I'm talking through the what will go away and what will stay, I think it's also important to remember that even these services, even though there will be some speech therapy, occupational therapy, and physical therapy codes that remain on the list of telehealth services through December 31st, 2023, the day that the public health emergency ends, so does the waiver that allows PT, OT, and ST to be eligible distance site practitioners. And I think that's important because that means even though the codes are here, they could continue to be provided by physicians, rehabilitation physicians, nurse practitioners, and delivered as telehealth services by those professionals. But unless something happens between now and the end of the public health emergency to also extend the eligibility of these therapy disciplines as distance site professionals, the fact that the codes are still on the list through December 31st, 2023 does not necessarily mean physical therapists, occupational therapists, and speech language pathologists can provide these services via telehealth and be paid for them separately. Another thing that I want to point out that's unique to the list of services for speech therapists on the current Medicare telehealth list, if you look at this column, some of the codes can be rendered as audio only services. So that's important too. Now, we didn't see that on the physical therapy list or occupational therapy list, meaning those have to be rendered in an audio visual technology even during the public health emergency. But there are a few speech therapy codes that could be delivered as audio only services through the end of the public health emergency. Now, what we do know, and these deadlines get confusing again, is that even though there are some codes that will continue to be available as covered telehealth services when rendered by an eligible distance site professional through December 31st, 2023, that even though they may still be covered, the audio only piece will go away when the public health emergency ends. So this will be a no once the public health emergency ends, even though the service itself could be delivered as a telehealth service by certain eligible distance site professionals when the public health emergency ends.
And we've
Right.
got a question in the chat on
Yes.
the codes. So are these, from Mitzi, are these the only codes that can be billed?
Okay, so that's a great question. No, not necessarily. What I pulled, I sort of filtered down on the telehealth list, those that kind of came from the primary speech therapy category. So I'm glad you asked that question. Physical therapists, occupational therapists, speech language pathologists can bill services as eligible distance site professionals, and can bill any codes within their scope of practice, within their benefits that they can provide and bill and be paid for under the Medicare program, if they are on the Medicare telehealth list. It's not necessarily limited to these codes for each discipline. These are just probably some of the more common codes for each of those disciplines. So the key there is in your scope of practice, is it on the list of covered telehealth services? And is it a service that is a Medicare covered benefit for your particular therapy discipline? And if the answer is yes, the fact that I may not have that particular code on this list next to speech therapy, it can still be covered and paid for by Medicare. Thanks for asking that question. So that's kind of where we stand right now. You can see this is going to get pretty darn complicated as the public health emergency at the federal level starts to wind down in terms of what's covered as a telehealth service, when rendered by whom, and audio only, or what type of telehealth modality. And in the midst of that, we've got a whole lot of other federal legislation going on. So what I'm saying today is kind of what we know today, but there are a lot of bills that could change a lot of those factors. We have bills that may make audio only a permanent modality for telehealth under the Social Security Act, meaning it's not something that Medicare would be changing service by service, saying this can, this can't. So we have bills that might make that change. We have bills that might make physical, occupational, and speech therapists permanently eligible distance site professionals under the Social Security Act. If that happens before the end of the public health emergency, we don't have to worry about this December 31st, 2023 date. So I say all of that and this is what we know right now, but kind of watch and see, because there are a lot of things happening at the federal level that could change that pretty significantly. So after the public health emergency, a couple of things happen that significantly affect therapy providers on a permanent basis, at least with what we know today. They would no longer be eligible distance site practitioners. However, there is still the ability after the public health emergency ends for therapy professionals to render services, what's called incident to the professional services of another healthcare provider. So the way that works in a normal environment, and I'm going to take the face-to-face environment first, and then we'll talk about how that extends to the concept of telehealth. Incident to services means we've got a provider who sees a patient and establishes a plan of care. So let's say that's a physician. And after that plan of care for a patient's condition is established, it is carried out by other professionals, typically professionals whose rate of payment may be lower than the physician's. If I think of the office setting, nurse practitioners or physician assistants are a common example of that, and they carry out the plan of care. Well, as long as they're carrying out the plan of care for a condition that has been established by a physician, and they're being supervised, they have direct supervision by a physician, then those incident to services by a nurse practitioner can be billed as if they were provided by the supervising physician. We bill them under the name and the NPI number on a line item basis under the supervising physician. So let's translate that to therapy. So if a physician, let's say it's a physical and rehabilitation physician, sees a patient and establishes a plan of care for therapy that is carried out by a therapist, then the therapist's services could be carried out and billed as services incident to those of the supervising physician. That is still a possibility, even when the public health emergency ends. And then translating that to telehealth services, we got clarification during the public health emergency that telehealth services can also be delivered incident to. So going back to kind of our normal medical example, if a patient has a telehealth visit with a registered nurse in a practice to do like a blood pressure check, I don't know, I used to see them for PT and INR clinics or something along those lines. But the nurse's visit is incident to the order and the plan of care of a physician. The nurse's telehealth service could be billed as an incident to, meaning under the name and the number of the supervising ordering physician. Telehealth can work the same way, as can telehealth services delivered by PT, OT, speech language pathologists within their scope of practice, but being rendered incident to the services of a supervising physician or other healthcare practitioner who is an eligible distance site telehealth practitioner. We could probably spend a whole hour just talking about that concept, right? It's pretty complicated. The other thing we know about telehealth, at least right now, and I think we're going to see more guidance on this in the upcoming fee schedule that will go into effect for 2023, is that when a telehealth service is rendered under the incident to model, so it's billed under the name and the number of the supervising physician or other professional. We know that typically in an office setting or an in-person setting, that the physician has to have a direct level of supervision, which means physically in the office suite where that actual rendering professional is providing the service and immediately available. Well, that doesn't really work in the telehealth modality. Like, what does that mean to be in the office suite where a telehealth service is being rendered? So what Medicare has given guidance on is that telehealth, that direct supervision requirement can be met through virtual presence, meaning as long as that supervising professional, the same way that they could step in and intervene or provide assistance in the office setting, as long as they can step in and provide assistance during the virtual telehealth session and they're immediately available, that can meet the direct supervision requirement for a telehealth service being provided incident to the services of the supervising professional. So all of that to say that can continue to potentially be, could potentially be an option after the public health emergency ends. The other thing I want to touch on are therapists that are in private practice. And prior to the public health emergency, therapists in private practice could potentially bill patients for services that were not covered by Medicare because it was outside of a benefit package. And they may do that as truly out-of-pocket private pay. They may, for various reasons, the patients exceeded their therapy benefits or whatever the reason may be under Medicare coverage rules, a therapist may provide those services and have the patient fill out what's called an advanced beneficiary notice, agreeing to pay for this service that is a Medicare benefit, but is not going to be covered because of exceeding benefits or therapy being provided too frequently, or it's not covered for your condition. whatever their circumstances may be, and the therapist has the patient complete an advance beneficiary notice so the patient agrees to pay out of be financially responsible for those services when and if Medicare declines to pay. So after the public health emergency, then physical therapists, for any service that, I guess, let me back up, during the public health emergency, that's no longer an option to bill the patient directly for a service that prior to the PHE was not covered, because therapists could not deliver teletherapy services prior to the PHE. So they might say, okay, patient Rochelle, if you want physical therapy through telehealth, I can do that. But it's not a Medicare covered benefit. So you have to accept financial responsibility for that service. That's no longer the case. Now that it is a Medicare covered benefit, it directly affects the way therapists in private practice who bill for their therapy handle those situations. Now, instead of Rochelle having to pay out of pocket for those services or signing an advance beneficiary notice, then the therapists bill Medicare for those services. And there's something called a mandatory claim submission rule that actually requires a Medicare participating provider to bill Medicare for Medicare covered services, with very limited exception to that. Now, in some instances, there are a couple of other rules or, I guess, compliance considerations that may affect the therapists in those situations. And one may now require therapists to enroll in the Medicare program, because some of these services are now Medicare covered services that weren't before, meaning the code itself was covered, but not in a telehealth modality. And so because it was a non-covered service, therapists doing teletherapy may not have had to enroll in the Medicare program to bill and be paid for services, and could handle that more in a model that looks like private pay, where now they would have to enroll in the Medicare program and have mandatory claim submission rules for those services. There are processes for Medicare opt-out rules for providers that don't want to participate in Medicare. And we haven't really touched on that in any of our education sessions, but for therapists in particular, where we've got this kind of weird space of their actual telehealth services were not covered benefits previously and now are, and then may in the future may not be again. It really has changed the financial dynamics of how their practice works and how the billing to and payment from patients works for those services. So now I'm going to switch gears a little bit and talk about outpatient therapy that is provided not so much in a private practice like a clinic setting, but more in a facility setting. So this might be in a hospital, in a rehab facility, in a skilled nursing facility where therapy is provided. So looking back at our timeline, we had April when April of 2020, when Medicare clarified that physical, occupational, and speech therapists could deliver telehealth services as eligible distance site practitioners. Then a month later, or about a month later, CMS said that institutional settings, facility-based settings, can provide outpatient therapy services via telehealth. So like in a skilled nursing facility, if a patient is outside of a Part A stay, the skilled nursing facility can provide outpatient or Part B Medicare therapy, and the facility can bill for that therapy on an institutional claim rather than that being done on a professional claim by the therapists themselves. And then there were some billing instructions on specifically how to do that. So this comes from the CMS FAQ. It was published at the end of May, and it explains exactly all of those claim indicators on how the hospital, the skilled nursing facility, and other types of institutional or facility-based settings would go about billing for outpatient therapy services rendered via telehealth. So
And
now
we've got a question for you in the chat. So from Joey, just for clarification, the incident 2 rule is not strictly an on-site requirement by the supervising professional. It is also met if the supervising professional is on virtual standby in case his or her clinical oversight is required during the telesession.
Okay, so great question. And yes, you've understood that correctly, that for the duration of the PHE, the direct supervision requirement can be met through virtual presence. And that's true of telehealth services. What we don't know, or I guess as I'm saying this out loud, I need to clarify, and I can send out after this session. When the public health emergency ends, we know telehealth being delivered in an incident 2 manner. That was a clarification that Medicare made that is not unique to the public health emergency, but it came to light as more providers were using telehealth as a result of the public health emergency. And Medicare said, yes, there's no difference in an in-person versus telehealth in terms of the incident 2 benefit that can be done via telehealth. So then we had to address the requirement that the supervising provider normally in a face-to-face modality has to have direct supervision, which is defined as in the office suite and immediately available. How does that translate to a telehealth service being done as incident 2? And the guidance was that direct supervision requirement for an incident 2 service can be met through virtual presence when it's done via telehealth. What I will check on that I can't remember off the top of my head is whether that clarification on virtual presence for incident 2 services via telehealth, whether that is permanent, because when the public health emergency ends, the in-person direct supervision requirement is likely to go back to in the office suite and immediately available. So I'll check on that piece as I'm saying that. That might have been a permanent clarification, but I can't remember. You're right on. You're right on though that the virtual presence means that supervising professional just has to be immediately available to intervene during the telehealth session.
Thank you. And we have one more question in the chat. Does that apply to hospital-based outpatient also? Can they bill on UB 82?
Okay, so let me kind of break this question down. Does the virtual presence during a telehealth session, let me say it again, does the virtual presence of a supervising provider during a telehealth session also extend to hospital services that are provided via telehealth and build on the institutional claim? Did I kind of summarize that, Christy? I guess I can pull up it in the chat and look.
Yes.
Okay, so hospital-based outpatient also. So I think this question is specifically referring to a setting that is structured and billed as provider-based hospital outpatient department, meaning it would look like a clinic, but it's wholly owned by the hospital. Patients are registered as outpatients of the hospital. And in that provider-based hospital outpatient department, if a telehealth service is rendered, then yes, thanks for letting me break that down, then yes, the telehealth service and the supervision can still be met through virtual presence of the supervising provider.
Did that answer the question, Mitzi? I just want to double check before we move on.
I think so, yes.
Great, thank you.
So in this same FAQ guidance, what I love about the FAQ that I'll also send out with the information after the session is that it has been a dynamic document in the sense that Medicare has added to this one document and made changes and clarifications rather than having a March document, an April document, a May document. It's kind of grown so much so that I was reading a reference saying, oh, you can find this particular question on page 70 of the CMS FAQ. And when I went to the CMS FAQ, it is now on page 90. So this thing has definitely grown over time as more and more questions are coming up for Medicare on the waivers, the flexibilities, and some different telehealth guidance during the public health emergency. So another question that's raised and addressed in this FAQ is what's happening for Part B, physical and occupational therapy services in particular, if it's part of a maintenance program, meaning it's Part B outpatient therapy services. It's not part of a Part A bundled payment, whether that's home health, whether that's a skilled nursing facility, et cetera. And so the answer from CMS was physical occupational therapists who want to provide maintenance programs can continue to do that when clinically appropriate. It applies to all provider settings. Now, also because physical and occupational therapists are able during the public health emergency to provide their services via telehealth, this then extends to when those maintenance therapy Part B services are being rendered via telehealth as well. Inpatient rehab facilities, can they admit patients who have a need for rehab, but typically in order to be eligible for inpatient rehab, just like a skilled nursing facility, there are some complexity, like a level of care requirement to show medical necessity for an inpatient stay versus receiving that therapy on an outpatient basis. And so one of kind of the parameters or criteria to be eligible for inpatient rehab is benefiting from 3 hours of therapy per day. So can we, an inpatient rehab facility, admit patients if they have rehab needs, but they may not necessarily need that 3 hours a day? They might only get 1 to 2 hours of therapy per day. And CMS clarified that there was a waiver early on under the CARES Act that waives that intensity of therapy requirement for inpatient rehab facilities. And now that we know with the clarified guidance that institutional settings like an inpatient rehab facility can also provide their therapy in a telehealth format. We read those two together, that 1 to 2 hours of therapy that we anticipate an inpatient for an IRF might need could also in whole or in part be delivered via telehealth. Okay, so this is referring to therapy, particularly in a skilled nursing facility setting. So in the skilled nursing facility setting, the facility is billing a single per diem, per day rate, and that includes all of the nursing care, the room and board, as well as the therapy services that the patient may need. And the amount of payment varies in part based on how much therapy and how frequently throughout the week the patient is needing therapy and how many disciplines of therapy are involved in the patient's care. So in this FAQ, if we're trying to avoid person-to-person contact with therapy in a skilled nursing facility, can some of those be delivered remotely or through telehealth type services? And we know based on the guidance from May, the answer to this in June 2020 was not surprising, that yes, those services furnished to patients in a Part A skilled nursing facility stay can be delivered in a telehealth format. However, if the patient is in a Part A stay where the facility bills a single per diem rate, that one consolidated bill encompasses the payment for therapy services, physical, occupational, and speech therapy are not separately billing for their teletherapy services. It is still part of the bundled payment, but the way they deliver the therapy in the skilled nursing facility can be provided through a telehealth modality. Can therapy services be paid separately in a Part A skilled nursing facility stay, or insert any other type of bundled payment mechanism like a home health episodic payment? And if the therapy services are part of that bundled payment mechanism, then providing the therapy via telehealth doesn't change the fact that the therapy being provided is part of a bundled payment, and doesn't necessarily cause it to fall outside of the bundled payment and be separately billable and payable. Can outpatient therapy be furnished and paid separately for patients who are receiving home health services? So this goes to the question that we had in the chat earlier. And generally, the answer is going to be no for patients who are under a home health plan of care and the home health benefit, where home health agency consolidated payment or episodic payment rate applies. Then the therapy provided, even if it's done through this different telehealth modality, is still a part of that bundled payment. Only if for some reason the therapy falls outside of the home health agency's bundled payment rate anyways, whether it's telehealth or not, would the therapy be billed separately? My goodness, I'm stumbling over my words today. So this is kind of a diagram that I thought was kind of helpful to look at. It's from the same CMS FAQ that talks about, well, who's going to be billing the therapy, and helps offer the decision on who bills, how they bill, whether that's on a professional CMS 1500 claim form, or whether it's on the facility or institution's UB04 facility bill, and then how that would work. And this is just kind of repeating the same question, but giving more specific billing guidance on exactly what modifier, on exactly what type of bill a facility or an institution billing for outpatient therapy services provided by the facility, where those outpatient therapy services are delivered via telehealth, how they would be reported on the claim. And the good news is, if we're billing it on a facility claim, the UB04 claim for the facility, there's no place of service field on that claim form. So we don't have to worry about whether the patient was at home or in assisted living or in a nursing facility. That whole element or complexity to the telehealth billing is eliminated when it's being done on the institutional claim. The other thing that I wanted to point out on this slide is this number 2, I think, is kind of interesting. If it's a hospital that we're talking about wanting to potentially bill for that outpatient therapy rendered via telehealth, there's this concept during the public health emergency of hospitals without walls. So if the hospital could register the location where the outpatient therapy is being provided as an outpatient department of the hospital, and this is how the billing would work. They register the patient as an outpatient, just like they would in any other provider-based outpatient setting. That's even if the patient is at home. Okay, so this hospital without walls concept is kind of interesting because it allows that same hospital outpatient provider-based billing and payment model to be used during the public health emergency for a patient's home. That the patient's home for billing purposes becomes an outpatient department of the hospital. And so we register the patient as an outpatient, whether the therapists are employed by or contracted by the hospital. They furnish the therapy care. It can be done through telehealth to a patient at home and billed as a hospital outpatient therapy service. Does this concept of direct supervision and the revised definition that allows virtual presence, does that also extend and apply to PTs, OTs? This question doesn't ask about speech language pathology in particular, but the same concept applies to speech therapists as well. Does that direct supervision through virtual presence also apply to their services? And so the answer is that yes, that direct supervision definition, allowing virtual presence of the supervising professional, which could be a PT supervising a physical therapy assistant. It allows the virtual presence of the supervising professional through the use of the interactive technology. So the PT, the OT, they can join that telehealth service. They're immediately available to join. In private practice, they have to directly supervise their assistants, which can be done through virtual presence when the assistants are furnishing services through telehealth. So I want to shift gears for just a second and talk about some state rules that deal with the therapy disciplines and telehealth in particular. So during the public health emergency, Medicare has relaxed the requirement and says they're not going to be auditing telehealth visits to see if there is a provider-patient established relationship during telehealth visits. So when I saw that waiver language, I thought, well, what does state law say once the public health emergency is over with respect to establishing the provider-patient relationship via telehealth, and in particular for therapists? Now, Kansas and Missouri are kind of in the same boat where their statutes on how the provider-patient relationship is established is not specific to the therapy disciplines. It's just in general, the concept of telemedicine can be used to establish a provider-patient relationship. And I put a little notation for Kansas there because there is a bill right now that may modify that slightly or determine specific circumstances on whether and how the provider-patient relationship can be established by via telehealth and audio only in particular, and by interstate telehealth providers in particular in Kansas. Now that hasn't been passed, it's just a bill at this time. Oklahoma, your statutes are more prescriptive in that there's telehealth statutes for all of the various professional disciplines, for physicians, for speech therapy, for physical therapy, and for occupational therapy. Physicians can create the provider-patient relationship through telehealth, while the provider-patient relationship via telehealth is not specifically addressed in the PT telehealth, OT telehealth, and speech therapy telehealth statutes. The guidance that I see interprets that same physician ability to establish a relationship via telehealth to also apply to the therapy disciplines. Now, I'm not licensed in Oklahoma, so I'll just tell you that's the guidance that I see on how to interpret the therapy telehealth statutes for Oklahoma. The other thing that's unique in Oklahoma, above and beyond what Kansas and Missouri describe for their telehealth statutes for the therapy disciplines, is that the speech, occupational, and physical therapy statutes are very specific in defining what telehealth means. Telehealth practice, telehealth is distinguished from telemedicine, teletherapy, and telerehabilitation are all specifically defined terms under your Oklahoma statutes. And so when we're looking at coverage policies, or when we're looking at requirements for different services rendered in a telemodality, we need to pay careful attention to what word is used: telepractice, telehealth, teletherapy, or telerehabilitation, because the definitions of each of those terms differ slightly, and we need to know what the definition is in a particular context to really understand all the rules of engagement for those services. And the last thing I'll leave off with before we wrap up and look at any additional questions at the end of the session is that all of this could change by the time the federal public health emergency ends, because there's one act in particular I saw on the ASLHA, the American Speech, Language, and Hearing Association's website, that they at least support or are advocating for the expanded Telehealth Access Act at a federal level would permanently make the therapy disciplines eligible distant site practitioners under the Social Security Act. So that would mean even after the public health emergency ends, as long as the service being provided is on the telehealth list and it's within that professional scope of practice under state laws, it could be provided via telehealth by the therapist and billed and paid for by Medicare. But there are many others that would accomplish that same objective in a little bit different ways. There's another bill at the federal level that would allow, the Department of Health and Human Services to define who an eligible distant site practitioner is, and not necessarily rely on the limited set of professionals that are already present in the Social Security Act, meaning those in the Social Security Act are minimums, and then Health and Human Services could add more professionals or define more professionals. What I like about the expanded Telehealth Access Act approach, at least from the perspective of the therapy disciplines, is that would open the door to really any telehealth service that you can provide under state law that's a Medicare covered benefit. What I like less about the idea of Health and Human Services defining additional eligible distant site practitioners is because that allows the Medicare program to kind of create caveats that I foresee could make that particularly complex for therapists. For example, speech therapists are eligible to render, they're eligible distant site professionals, but only for PT evaluations and not for the therapy modalities. So it makes it a little bit more complex, I think, to approach it in that way. Those are two approaches, but there's probably 5 to 10 different federal bills right now that all include as a component expanding the list of eligible distant site practitioners in a way that would permanently benefit the therapy disciplines for telehealth under the Medicare program. So we'll keep our eyes on that and certainly keep everyone apprised of any changes that are happening at the federal level in that sense. I'll also add, before I wrap up, just yesterday, I'm on a work group for the American Health Information Management Association, their policy and advocacy work group, where we were talking about some federal bills or federal regulations that are in the works. And next month, when we have our meeting, we're going to be talking about bills that are in the works on telehealth in particular. And this was a question that I raised yesterday that I'd like to talk about at that next meeting. So I may have more information in about a month of kind of the inside scoop on what folks in Washington or what folks with the Department of Health and Human Services may be thinking in terms of rulemaking that may affect telehealth with respect to therapy disciplines on a permanent basis after the PHE ends.
Thanks, Rochelle. So much information as always, and we'll put the HTRC email address in the chat. If you have any follow-up questions now or later, you can email them to us and we'll get those to Rochelle to get you an answer. We will email the recording and the follow-up email as soon as we can. And we hope you can join us for the next webinar, which is March 16th at noon. And we'll discuss policy, building, and guidelines around telehospice and telepalliative care. Thanks, everyone.